Hello, everyone. Happy afternoon. A very good afternoon. I hope and I believe all of you are doing well. A quick nod whether I am audible and visible to everyone. Let me just check. I'm not able to see it. Yes. Yes, this will be helpful for the upcoming exam as well. और इसके other episodes video कहाँ है? You can find all the links on my Telegram channel there, right? Hi, good day and good afternoon, Rishi and everybody here. So here we are. Hi, Bhushan, good afternoon. So this is the FAST episode 13. Again, for students who are new here, just to tell you what is FAST. FAST is First Aid Simplified Teaching. What is first aid? The USMLE first aid step 1 book basically is what we are going to discuss here. Yesterday we had the part 1 of general pharmacology. This is going to be part 2, continuing with the rest. So if you have not watched the previous, the last episode, please watch it after this class so that, your general pharmacology, basically the important points will be covered here in both these sessions, right? So if you have your first aid with you, you can annotate the same or you can make notes with me as we are discussing. Right. So starting with this one, and before that, few updates about what's happening on the platform. So you have bigger savings unlocked now at Unacademy. This is valid till 30th of June, and you get 25% off on all the subscriptions. So for the NEET students, NEET PG or the next students, we have the 6 months batch which is going on. With the current offer, you get it around like 14K. And for the FMG students, we have a 2 months subscription on the Unacademy store at around 4.5K. And you can use the code Dr. Nikita while subscribing. We also now have a NEET PG Vitals. Vitals is basically the recorded classes, studio recorded classes that we have for all the 19 subjects. So you can watch the classes at your own pace as well. Right. And we've also launched this ACE Next batch, like I mentioned, on Unacademy store on June 21st. Right. So this is on the store. These are not the live classes. These are the recorded classes. And you can get access to this batch at just 6K with the code again. Okay. Disha, please watch all the sessions of pharmacology that I have taken. I'm sure that will help you to make your pharmacology strong, right? Because on the contrary, pharmacology is like one of my top favorite subjects. So I personally love it, and that's why I love to teach it as well. Okay. And for the FMG July students, we also have the FMG Final Frontier batch, which is available at the Unacademy store. And you can get that at around 3K is what you can get it. Okay. So let's start with the discussion of the topics for today. That is efficacy versus potency. इसके पहले वाले जो topics है general pharmac से, we had done that yesterday. Continuing the yesterday's session, and we have one more session tomorrow at 9 a.m. We have the YouTube live session where it's basically going to be a mnemonics marathon, right? All the important mnemonics that we have been discussing so far. Right, we will try and get them all, and a lot of mnemonics, like, we will be going through them with the help of the MCQs, right? So this is what we are going to do tomorrow, 9 a.m. as well. Okay, and we will also have the last KBMD tomorrow. That's a free live class on the app. So we will have the last KBMD basically tomorrow at tomorrow at 7 p.m. we will have the KBMD. So be there on the app and the YouTube session there. Okay. Right. So starting with the discussion of the topic for today, that is efficacy versus potency. I told you a mnemonic yesterday. Do you remember that? The mnemonic was HELP. What is HELP? The height indicates the efficacy. The leftward drugs is the potent drug. Okay, that's the potent drug. So remember that efficacy basically is the height. Height matlab the maximum height, the maximum effect that can be seen is the efficacy, right? Irrespective of dose. Okay, irrespective of the dose. So let's say that there is drug A and there is drug B. If I tell you that both of these drugs are the drugs used in diabetes mellitus to decrease the blood glucose levels. So let's say that when you give 10 milligram of drug A, it decreases the blood glucose levels by 20 milligram per deciliter. When you give 10 milligram of drug B, it decreases by 30. When you give 20 milligram of drug A, it is decreasing the blood glucose levels by 40. Right, and when you give 20 milligram of drug B, it is still decreasing the blood glucose levels by 30. Which of these is more efficacious? Drug A, because the maximum effect, irrespective of the dose, ज़्यादा दे रहे हो कम दे रहे हो वो फर्क नहीं पड़ता कि maximum effect वो कितना दे रहा है. That is what is the efficacy. Remember that efficacy is the maximal effect a drug can produce, and it is indicated on the y-axis, that is the vertical, that is the height. The Vmax, right? The increase the height, increase the Y value, increase the Vmax, increase the efficacy. Is this in any way related to potency? No. Efficacious drug can be less potent or it can be more potent, right? So like for example, in this case, जब 10 milligram drug A का दिया तो it is decreasing 20, 10 milligram B का दिया तो वो 30 का है. So with the same dose, a drug which is having more effect, that is more potent, right? So here drug B is more potent. So remember that efficacious drugs can be high or low potency, and definitely partial agonists are less efficacious than full agonist. Potency we cannot comment, but we know that for partial agonists, they have less effect. They are partial agonists, right? So look at the image here. So the x-axis showing the log of drug dose, and this is the maximal effect. जो ऊपर है जिसका ग्राफ सबसे ज्यादा है, Vmax जिसका ज्यादा है, that is going to be more efficacious. All I want you to remember here is help. Height is efficacy, left is potent. Okay. Going to the next one, potency. What is potency? So to produce the same effect, how much is the dose required, the amount of the drug required? So it's coming back to this example that this drug, ठीक है, मैं यहाँ पे लिख लेती हूँ drug A and drug B. Drug A and drug B. To decrease the blood glucose levels by 20, you need 5 milligram of drug A and 10 milligram of drug B. Which is more potent? Drug A is more potent. Basically, to produce the same effect, which drug is requiring less dose? That is your potency. And it is the drug dose. So basically, it is on the x-axis. The left wala is more potent drug. Right, the left wala is more potent drug. That is what we should know. So the potency is represented by the X value, that is EC50, producing the effect in 50%, right? The effective concentration for that. The leftward shifting basically is decreasing the dose and increasing the potency basically. Okay, that is increasing the potency. Is this clear with everyone? What is EC50 here? To produce the 50% of the maximum effect, how much amount of dose is required? That is EC50. So जिसका EC50 कम होगा, that drug is going to be more potent. Remember again, this is unrelated to efficacy. Okay, it is unrelated to efficacy. So this one mnemonic will help you understand and remember this. Remember the mnemonic is help. Height is efficacy, left is potent. Okay, the more height is the more efficacious, more left wala is more potent. Very, very important. You get question on this very frequently in the exam. Okay, very, very important. Going to the next one now. What do we have in the next one? That is the receptor binding. Okay, the receptor binding, whether it's a competitive antagonist, non-competitive antagonist, or it's a partial agonist. Okay, or it's a partial agonist. So yesterday we had seen the trick for this. अगर competitive होगा, how do you remember the trick yesterday we had discussed? Competitive and non-competitive का graph कैसे decide करता है? Competition is with the same level person, right? So competition reaches the same level, and non-competitive is below. Okay, non-competitive is someone who's at a lower level, not competing, तो वो हो जाएगा नीचे. So the drugs which are reaching the same height, same level, that is basically competitive. So with competitive, what is unchanged? What is unchanged with competitive? It is the maximum height, same level. That means the Vmax is unchanged. We had seen that the Km increases. If the Km increases, do you remember from yesterday's class what happens to the affinity? If the Km increases, what happens to the affinity? Yes? If the Km is increasing, what is happening to the affinity? Very good. The affinity is decreasing. Okay, the affinity is decreasing. So look at this one. This is just the agonist and this is the agonist with the competitive antagonist both given together. Where is the graph shifting? The graph is shifting towards the right side. Okay, the graph is shifting towards the right side. That means the potency is decreasing. There is decreased potency is what we are seeing here. Okay, and what do we have next here is with non-competitive is below. That means the efficacy is decreasing with non-competitive. Okay, the efficacy is decreasing with non-competitive, right? And what is happening with partial agonist? With partial agonist, definitely the efficacy is decreasing because the maximum effect that we are getting is decreasing. But look at the potency. It can be leftward or it can be rightwards. That means increased potency or decreased potency, we don't know. Right? So partial agonist can be less potent or it can be more potent, but basically the efficacy is reduced. Okay, the efficacy is reduced. Very, very important. Right? So let's have a look at this table here, which is summarizing these effects. Competitive antagonist, the same height. That means the efficacy is not changing. It is the potency which is decreasing. So that means it is the shift to left or shift to right if the potency is decreasing. It is the shift to right because left is more potent. With non-competitive antagonist, there is no change. It is the efficacy which is changing. The level comes below. With partial agonist, potency can be less or potency can be more, but definitely the efficacy is decreasing. Okay, the efficacy is decreasing. Competitive antagonist basically can be overcome by increasing the agonist concentration. Yesterday we had seen that the substrate concentration badhaoge, so then it can be reversed. So basically this is, we are talking about the reversible competitive. Non-competitive cannot be overcome by increasing the agonist concentration because the non-competitive, so let's say that this is the enzyme. If this is where the agonist is binding, the non-competitive antagonist binds at another site. So even if you increase the agonist concentration, the conformation has changed here. The agonist will not be able to bind. Remember that this cannot be overcome. Partial agonist acts at the same site. What are the examples of competitive antagonists? Diazepam, flumazenil. Remember for diaze, it is flumazenil, which is the competitive antagonist. What receptor does this act on? This acts on GABA A. Right? Remember that benzodiazepines, barbiturates, they act on GABA A. Baclofen acts on GABA B. Okay, so that is GABA B. Next one, which is non-competitive, phenoxybenzamine is a non-competitive antagonist on alpha receptor for norepinephrine. Do you remember norepinephrine, noradrenaline does not act on which receptor? Noradrenaline does not act on which receptors? Is it alpha 1, alpha 2, beta 1, beta 2? It does not act on which receptor? Absolutely right. It does not act on beta 2 receptor. Very good. It is not acting on beta 2. Remember, noradrenaline does not act on beta 2 receptor. This is so alpha receptor non-competitive antagonist. Which is a partial agonist? Remember, buprenorphine is a partial agonist at opioid mu receptor. So remember that when I say buprenorphine, it sounds like morphine. That means it is look-alike of morphine, but not complete lookalike. So it's a partial agonist. Okay, it's a partial agonist at mu receptor. Very, very important and a frequently asked question. At mu, buprenorphine is a partial agonist. Going to the next one, the concept of therapeutic index. Now, first of all, what is the formula for therapeutic index? Remember it as TILE. That is therapeutic index, L comes before LD50 upon ED50. That is what is therapeutic index. That means how much dose is required to kill 50% of the animals or upon the drug to be effective in 50% of the population. You can also remember it as TITE, that is therapeutic index is TD50 by ED50. Because in human studies, you do not wait for the humans to be killed. It's basically the toxic dose in 50% of the population. You look for the toxicity. So remember that TILE therapeutic index is TD50 by ED50. Okay, it is TD50 by ED50. And what is this therapeutic index a measure of? Very, very important and a frequently asked question. This is a measure of drug safety. Okay, this is a measure of drug safety, not the drug potency or efficacy. It is the median toxic dose upon the effective dose. That is what is the formula. What is the therapeutic window? As the term says, it's a window, the concentration of the drug between which the drug is effective and safely effective. It is not causing toxicity. So what is the therapeutic window basically? So if this is the window and this is the window for drug A and drug B. One drug is having narrow therapeutic window or therapeutic index, and this is a wide therapeutic index. Which drug is safer out of this? Is it drug A or is it drug B? Which drug is safe out of this? Is it drug A or drug B which is going to be safer? Yes? Very good. Yes, correct. Chandni Dhwani V. It is drug B. This का window ज़्यादा रहेगा. That means you have a lot of window to change the drug concentration without causing toxicity. If the window is narrow, that means this is the dose concentration at which the drug is effective. This is the dose at which the drug is toxic. So the window is very less. So the safe drug, the effective dose can change to toxic dose very easily if the drug levels increase even by small value. So that is why in drugs with narrow therapeutic index, what do we need? We need therapeutic dose monitoring. Okay, we need monitoring of these drug levels because थोड़ा सा भी level बढ़ गया तो toxicity हो सकती है, right? So this is what is mentioned here, that safer drugs have higher therapeutic index values. The lower therapeutic index value drugs, they require monitoring. What are the example? Warning, these drugs are lethal. That is warfarin, theophylline, digoxin, anti-epileptic drugs and lithium. Right? We measure the dosages of these drugs. Right? Very, very important. We measure the concentrations of these drugs. So warfarin, theophylline, asthma drug, digoxin, anti-epileptics, lithium are narrow therapeutic index. Okay. Now, one of the questions asked in the exam was, calculate the therapeutic index from the graph. And you were given this graph and let's say this value was also given, कि 100 है और ये है 50. So what is going to be the therapeutic index for this drug? So TI is TD50 upon ED50. Toxic dose TD50 is 100 and effective dose is 50. 100 upon 50, so the therapeutic index is 2. Okay, the therapeutic index is 2. Is this clear with everyone? Right, correct. So this is what is the therapeutic index. Basically, remember, you do not subtract, you divide it. Okay, you do not subtract, basically you divide it. So 100 upon 50, it is going to be 2. Okay, so therapeutic index, very, very important, is a measure of drug safety. Okay, remember that it's a measure of drug safety, right? So coming to the next one, the drug effect modifications. Very, very important. What do you mean by two drugs are additive? They have a permissive effect, synergistic effect, potentiating, antagonistic or tachyphylactic. Tachyphylaxis has been asked in one of the recent FMG exams also, so this is important. Additive matlab, we are just adding, like 2 plus 2 is equal to 4. That means you have two drugs, which is drug A and drug B. Both of them are having the effect on that particular system. When you give both of them together, you see adding the additional effect. So when you give the two substances A and B together, the sum of the individual effects is what you get. But suppose now I tell you that when I do 2 plus 2, but now the addition is 5, it's not 4. That means it's more than 4, it is more than addition. So what is that drug called as? Or what is that interaction called as? When you give a drug A and when you give a drug B, both together, the effect is more than A plus B. A plus B together, 2 plus 2 basically is coming more than 4. What is that called as? Like you see here, that is called as synergistic. When it is greater than the sum of their two individual effects, then it is synergistic, like clopidogrel and aspirin. When you give them together, they have much more antiplatelet effect. Very good, Chandni. That is synergistic. So 2 plus 2 is more than 4. Additive is give them together, you see the additional effect. What do you mean by potentiation? What do you mean by potentiation? So here also basically the additional effect is more than the individual, but the second drug that you are giving, the drug B, does not have therapeutic action by itself, but it is enhancing the effect of drug A. Example, when you give carbidopa with levodopa, is carbidopa doing anything per se? Is it doing anything per se in your Parkinson's disease dopamine pathway? What is it doing? It is only blocking the enzyme which degrades this levodopa, right? Which converts this levodopa to L-dopamine. Then it will not cross the blood-brain barrier. So you do not want this to happen, and that is why we give carbidopa, right? The peripheral, the decarboxylase inhibitor. So remember that 2 plus 0 is more than 2. The drug B does not have any action. That is what you need to know here. So potentiation basically is increasing effect but without any action. The other drug does not have any effect by itself. Right? It does not have any therapeutic effect by itself. That is potentiation. What is permissive effect? This is a previously asked question. So why in asthma you give steroids with salbutamol? Why are both given together? So cortisol on catecholamine responsiveness के लिए, it's a permissive effect. That means you require these steroids for the full effect of salbutamol to be seen. So the presence of substance A is required for the full effect of substance B. So that is what is permissive. It is permitting the full effect of the drug. It is required for the full effect of another drug. Okay, so remember that. Is steroid by itself good in asthma? Yes, because it has anti-inflammatory properties, though not bronchodilator properties, but it has anti-inflammatory properties, right? But for catecholamine ka full effect, we need steroids to be there. So remember that is permissive. Antagonistic, as the term says, nullifying each other. So the effect is less than the sum. If you give both of them together, the effect is less. Morphine का antagonist क्या होता है? Naloxone. Naloxone is morphine का antagonist. What is tachyphylaxis? Tachy मतलब fast. So when you are giving a drug very fast, as mean in repeated doses, the response decreases. Acute decrease in response to drug after the repeated administration. That is what is tachyphylaxis. तो पहले इतना इफेक्ट है, फिर इतना इफेक्ट है, फिर इतना इफेक्ट है, फिर इतना इफेक्ट है. So basically this is tachyphylaxis. If you give a drug repeatedly, the response is decreasing. Example, repeated use of decongestants like oxymetazoline, you will see decreased response and there can be rebound congestion is what you can see when you stop the drug. Right? I hope everybody is clear with these terms now. So additive is basically two drugs, 2 plus 2 is equal to 4. Synergistic is 2 plus 2 more than 4. Potentiation is 2 plus 0 is more than 2, right? This drug is increasing the effect. Permissive is cortisol basically with catecholamines, antagonistic and tachyphylaxis. Decreased response when you give the drug on repeated administration. That is what is tachyphylaxis. Okay, that's tachyphylaxis. Clear with everyone? Got this concepts? So I hope this part of general pharmacology basically from your first aid is complete if you look at part 1 and part 2. So now what we'll be doing is we'll be solving some numericals based on whatever we have discussed, and let's start with that. Okay, this is your first question. Tell me, what do you think will be the answer to this one? Let's see who gets this right the first. What do you think will be the answer to this one? The question is, which of the following is the most appropriate oral loading dose of drug A? Chandni, why do you call it A? So there is, one trap there. Very good. DK, that is 400 milligram is the answer. Why? Because first of all, remember that when the loading dose is asked, what is the formula for loading dose? It is LVP, right? So it is volume of distribution into the plasma concentration. How much is the volume of distribution given? Remember, it's given as 2 liters per kg. Yesterday, I had mentioned that whenever it's given in liters per kg, multiply it by the patient's weight. So 2 liters per kg actually makes a VD as 120. 2 into 60, it's not 2. How much is the plasma concentration? It is 3. But this is an oral drug. So we need to divide this by the bioavailability fraction. How much is the bioavailability? It is 90%. That means 0.9. Right? So 0.3, 120 by 0.3 makes it 400. Okay, that is why the answer is 400. Is this clear with everyone? Right, so do not just do this is 2 into 3. This is not just LVP. It is volume of distribution into the plasma concentration upon the bioavailability. Right, upon the bioavailability is what you need to do. Very, very important. Okay, don't make mistakes like this, because this is like a silly mistake that we generally tend to make there. Okay, and remember that the volume of distribution should be in liters. It should not be in liters per kg. It should be in liters. Okay. Next one, what do you think would be answer to this one? Which of the following, whenever you have lengthy questions, numerical questions, the trick is first you should be reading the last line. Which of the following best approximates the time for the drug to reach the steady state concentration? The time for the drug to reach the steady state concentration is which of the following? Remember, we had seen that? Absolutely right, DK again, it's B. The time to reach the steady state is 4 to 5 half-lives. Is it dependent on anything else? No, it is irrespective of the volume of distribution, of the clearance, of the dose, of the dosing. It is just the 4 to 5 half-lives. If the half-life is 12 hours, so 4 to 5 is 48 to 60 hours is what is the time. 48 hours is given here in the option, so we'll go with 48 hours. Remember, it is 4 to 5 half-lives that is required for the drug to reach the steady state. Next one. What do you think will be the answer to this one? Yeah, Chani, to be more specific, it was 3.3 half-lives. है ना, check करना first aid में. Yesterday we had seen it was 3.3 half-lives. What do you think would be the answer to this one? Very good, DK. Amazing. That is 120 milligrams. Because what is the kinetics that the drug is following? Here it is zero order kinetics drug. You are giving 200 milligram. In 90 minutes, 40 milligram was cleared. So how much will be left in the body after 3 hours? So you're starting with 200 milligram. And they have told you that in 90 minutes, basically it is minus 40. So after 90 minutes, it is 160 milligram which is remaining. 3 hours basically means how many minutes? It means 180 minutes. So you need to have another 90 minutes. Okay, you need to have another 90 minutes ka duration. This is zero order kinetics. In zero order kinetics, constant fraction or constant amount. What is eliminated in zero order kinetics? Is it a constant amount or is it a constant fraction? Right, it's a constant amount. Amount is zero. Fraction, constant fraction goes in first order kinetics. Constant fraction goes in first order kinetics. So 90 minutes में next 90 minutes में कितना जाएगा? First 90 minutes में 40. तो next में भी minus 40 होगा. So minus 40, 160 minus 40, it is going to be 120. Okay, so the answer will be 120 because it is zero order kinetics, right? Let's go on to the next question here. Similar question. The only thing that I've changed here is from zero order kinetics, we have made it first order kinetics. From zero order kinetics, I've made it first order kinetics. What will be the answer to this one? Yes, what will be the answer now? So we started with 200 milligram. Now again in 90 minutes, how much is going? It is 40 milligram. So 160 milligram is remaining. So the next 90 minutes again. Now, no, it is not C. Why C? Is it T? No. Therefore, this is first order kinetics. So it is constant fraction that will be eliminated in a particular time. So if in the first 90 minutes it is 40 milligram. Yes, very good, Disha. It's D. 40 milligram, matlab how much is the fraction? 40 upon 200, it is 1/5 of the drug which is getting eliminated. So in the next 90 minutes, 1/5 of 160 milligram is what will go, not 200 milligram. So 1/5 of 160 is 32 milligram. So 160 minus 32, it is going to be 128. Remember that in first order kinetics, it's a constant fraction of the drug that gets eliminated every same amount of time. So first 90 minutes में अगर 1/5 गया तो next 90 minutes में इसका 1/5 जाएगा, फिर इसका 1/5 जाएगा. So basically it remains the same. T half is constant in which kinetics? It is first order kinetics. T half clearance is constant in first order kinetics. With zero order kinetics, the T half goes on decreasing. Okay, the T half goes on decreasing. Going to the next question, this should be easy one. Drug remaining in the body after 3 half-lives. What is the drug remaining in the body after 3 half-lives? I don't think there should be any doubt here, even if you don't know how to calculate. Obviously, after 1 half-life, how much drug is remaining? 50% is remaining. 50% gone, 50% remaining. So with more half-lives, basically 2 half-lives, 3 half-lives, 4 half-lives, it will be less than 50%. Okay, it will be less than 50%. None of the option is less than 50%, and automatically the answer becomes A, because all the rest of the options are more than 50%. Okay, so remember that this is less than 50% is what will be eliminated. So after one half-life, 50% remaining. After two half-life, 50 plus 25, 75 gone. It is 25% which remains. After three half-life, how much remains? 12.5% remains, right? The amount remaining goes on decreasing. The amount eliminating goes on increasing. Okay, that is what basically the concept is. We have seen this yesterday again. Okay, we have seen this yesterday again. Going to the next one, what will be the answer to this one? Which is correct concerning the safety of using warfarin, which has a small therapeutic index, versus penicillin with a large therapeutic index? Warfarin versus penicillin. Which of these is correct? Okay, Brinda, it's not C, because if you look at the option here, the high therapeutic index makes penicillin a safe drug in all patients is incorrect, right? Your safety of a drug is not only on your therapeutic index, basically, an adverse reaction. The side effects of the drug, which are like penicillin has anaphylaxis wala anaphylactoid reaction, which can occur irrespective of the dose, right? So remember that it is not safe. It does not mean that it's safe in all the patients. There will be no side effect, right? This is correct, because warfarin treatment, if the bioavailability is altered, that means the drug concentration will change and there's a high chance of dangerous adverse effects because it's a small therapeutic index. So even if you change the drug concentration by some value, there can be toxicity. Okay, this is a correct statement. This is not a fully correct statement. It's a partially correct statement. It is not guaranteed कि wide therapeutic index means ये safe ही safe है. There are of course the reactions which are independent of the drug concentration, like the anaphylaxis to a drug, example penicillin. So remember that B is the correct statement here. Okay, it's the B which is correct. Next one, what will be the answer to this one? What do you think will be the answer to this one? What do you think would be the answer to this one? What answer are you looking for? Very good, Disha. Yes, Chandani, correct. It is D. How do you calculate this? This is given that you have started an infusion of a drug in a patient at this rate. And volume of distribution is given, clearance is given, and what will be the drug concentration at steady state. So what do you need to see here is, when you have started an infusion of the drug, this is not a loading dose that we are talking about. It is basically the maintenance dose wala. जब infusion start किया है, what is the formula for the maintenance dose? Maintenance dose is MCP. That is, maintenance dose is equal to clearance into the steady state plasma concentration. So the question is, what will be the drug concentration? The steady state plasma concentration will be the maintenance dose upon the clearance. It will be maintenance dose upon the clearance. What is the maintenance dose? Basically is the infusion rate or the elimination rate. Yesterday we have discussed that maintenance dose is equal to the infusion rate, which is also equal to the elimination rate, right? That's the steady state. Absolutely. The maintenance dose is 200 milligram per hour. This is in minutes, this is in hours. The units have to be checked when you are solving the numericals. 200 milligram per hour basically means 200 milligram per 60 minutes, and divided by clearance, it is 100. Right? So basically this will become 200, right, upon 60 वाला. फिर आंसर क्या आएगा यहाँ पे? What is going to be the answer? What is going to be the answer here? It is 3.3. अगर आप सिर्फ 20/6 भी करो तो 3.3 आएगा. Here it is not given in ml, it is in liters, right? So you will have to multiply it by 1000 as well, right? This is ml per minute. You want it in liters, तो ये multiply हो जाएगा. So just need to calculate कि 20/6 3.3 के आसपास होता है. So this will be 33.33. 3.33 वाला. This is in milligram per liters. Okay, it is in milligram per liters. Is this clear with everyone? Right? So this is what the answer is going to be, because 100 ml per minute basically will become 0.1 liters per minute, because 100 ml is 0.1. So 200 upon 60 into 0.1. So that is 2000/60. That is 33. That is what the answer will be. Going to the next question here, what will be the answer to this one? Calculate the maintenance dose. Straightforward question. ड्रग के लिए सब कुछ दिया हुआ है. Calculate the maintenance dose. Calculate the maintenance dose for a drug which has 100% oral bioavailability and which needs a target concentration of this much. What do you think will be the answer to this question? Yes, who's getting it right first? Very good, Sahil. Absolutely right. It is D. So remember that MCP, maintenance dose, is clearance into plasma concentration. But at the same time, remember that you have to divide it by the bioavailability. And for maintenance dose, you also have to divide it by the dosing interval. You have to multiply it by dosing interval. Multiply, not divide. So what is the dosing interval in this patient here? What is the dosing interval? We are giving the dose QID. That means 4 times in a day. That means how much is the dosing interval? 6 hours, right? It's 6 hours. कितने duration में दे रहे हैं? 4 नहीं, doses दे रहे हैं 4. मतलब कितने time में दे रहे हैं? We are giving 6 hourly. So the dosing interval is 6. The bioavailability is 100%. That means how much? It's complete. It's 1. Clearance is 20 and the plasma concentration is 2. Okay, so the plasma concentration is 2. So 20, 240, 46, 240. So this becomes 240 milligrams. Okay, this becomes 240 milligrams. Is this clear with everyone? Right, so the answer will be 240 milligrams. Remember, you have to multiply by dosing interval. If you are giving the drug OD, that means it is 24 hours वाला. अगर BD दे रहे हो तो dosing interval 12 hours है. अगर TDS दे रहे हो तो dosing interval 8 hours है. और अगर QID दे रहे हो तो dosing interval 6 hours है. Right? So that is where you have to put the dosing interval that needs to be put there. Okay, the dosing interval needs to be put there. Clear with everyone? Right? That is what you need to know here. Coming to some other points in general pharmacology which have not been discussed here. Quick points about the clinical trial. Okay, some quick points about clinical trial. Remember that the clinical trial phase 1, phase 2, phase 3 and phase 4. When is the drug sent for FDA approval for marketing? न्यू ड्रग अप्रूवल कब भेजते हैं एफडीए के पास? It is here after the phase 3, right? After the phase 3, then the drug is marketed, right? So basically the phase 4 is post-marketing surveillance. For rare side effects, long-term side effects के लिए post-marketing surveillance. In which of these do you start with the patients? The drug is given first time in the patients of a particular disease. Is it phase 1, phase 2 or phase 3? कहाँ पे patients में देते हैं? Absolutely right. The phase 2 starts with the patients, small number of patients. Phase 1 is in healthy volunteers. Phase 1 is in healthy volunteers. Why do you want to do phase 1 of a drug in healthy people? Basically to look for कि it is safe in humans, how are the pharmacokinetics. तो safe है कि नहीं humans में, कैसे ये drug eliminate हो रहा है, pharmacokinetics वगैरह देखने के लिए we do it in phase 1, healthy people. Once we have seen that yes, we can give it in human beings, then we give to the patients, right? Then we give to the patients. And then in phase 3 is basically the comparison wala phase, which is RCT, the randomized controlled trial wala, right? The patient will be given either a placebo or a new drug or an old drug versus a new drug. Randomized controlled trial, remember RCT, 3 letters, is done in phase 3. So this is where you confirm the efficacy of the drug as compared to the previous one. Okay, as compared to the previous one. Here we see that whether the drug is effective in a particular condition, is it actually decreasing the blood glucose levels in diabetes patients or not? This is where we look for the efficacy. कि कितना कम कर रहा है. Phase 3 में we compare it with the previous drug. Once it is proven that it's better than the previous drug, then we send for approval for marketing. That is phase 3. Okay, that is phase 3. That is clinical trial. And what drug schedule basically is related to conducting a clinical trial. In India, what is that drug schedule which is related to the clinical trial? Yes, what drug schedule? It is why. Okay, why? So remember why do you want to conduct a clinical trial is the question that you'll be asked. Remember that schedule Y is for clinical trial. H nahi. H किसके लिए होता है? Remember H is for a drug which requires a prescription. Drug sold only on a prescription basically is schedule H. है ना. H मतलब it requires health practitioner. H for health practitioner का prescription. What is the schedule for the drugs which are to be given under supervision? Drugs which are to be given under supervision is what schedule? Right. Supervision basically is G. G for guidance. Okay, G for guidance. A drug which can have side effects which needs monitoring to while being given. Remember, it is guidance for giving the drug. Okay, under guidance it is to be given. Then it is G. What is schedule X? And what is category X? What is a drug schedule X and a category X drug? X मतलब नहीं देना है ये drug because it has dependence, it has abuse liability. Psychotropic drugs. Right. Category X matlab teratogenic drug. This is related to pregnancy. Right. Thalidomide causing phocomelia. That is your category X drug. So this is related to pregnancy categories and the schedule is related to the psychotropic drugs. So remember these drug schedules, at least the H, G, Y, X, these are very, very important. Okay. These are very, very important. What is the schedule for a drug where a drug is sold under generic names itself? A drug is sold under generic name. Then what is the schedule for that? Yes, that is the schedule W. W matlab वैसे ही. W वैसे ही in the same name the drug is sold. So that is the schedule W. What is the schedule related to the expiry of the drug? Expiry is basically what is the period of life of the drug. How much is the period of life? So remember it is schedule P. Okay, period of life is schedule P. A drug for a condition which cannot be cured, like cancer wale drugs cannot be cured, is it comes under your schedule J. Right? J matlab जानलेवा conditions, cancer, HIV वो सब right? So remember that schedule J is basically for the conditions which cannot be cured. Okay, that is J. Right. So yes, that was about the today's session and the yesterday's session combined. So that is your majority of the topics that are covered here in general pharmacology. Just one more example which I remember is, if you get a question that adrenaline versus histamine on the effect on the bronchus, what kind of antagonism is this? What kind of antagonism is this? Adrenaline and histamine. Very good, Chandi. That is physiological antagonism. Physiological antagonism है ना श्रेयस? This is not chemical. Chemical matlab, like the chelating agents are the chemical ones, which is binding with the drug itself and forming a complex. That is your chelators are the example. Okay. Adrenaline is causing bronchodilation. Histamine is causing bronchoconstriction, but they are acting on different receptors. Okay, the antagonism which you see because of the drugs acting on different receptors and they are producing opposite action. Antagonism means opposite action, but by acting on different receptors, then it is called as physiological antagonism. Chelators are going to be example of chemical antagonism. They bind with the drug itself and form a complex with it. That is what is chemical antagonism. Okay, that is what is chemical antagonism. Okay. All right. So, like I mentioned, when do you have the next session for tomorrow? The next session for tomorrow is 9 a.m. is YouTube live session where it's going to be mnemonics like mega marathon is going to be there. And then at 7 p.m. We have the special class on the app, which is a free live class. We will have a KBMD tomorrow. Okay, we will have a KBMD tomorrow. Okay. So yes, that was about the today's session, guys. Thank you so much for joining in. I hope this has been a quick high yield revision of general pharmacology. Right. And see you again tomorrow at 9 a.m. Till then, goodbye, take care, and keep studying, keep revising, and keep winning. Thank you.